My name is Shahid Rafiq. I'm the chair of Apna Merit, and it's my pleasure and honor to welcome you all. And this Sunday webinar is on different aspects of COVID when we started also addressing the psychosocial aspect through just Rozina's ultrasound webinar focused on COVID is also a one of in the series of these webinars on Sunday. On Saturday, we have started a different webinar, which is for clinical management. And so those are based on actual case discussions from different institutions. So yesterday we hosted Rawalpindi Medical University, and they presented their cases, 5 of them, and they were discussed. So next Saturday is Military Hospital Rawalpindi, which is a COVID center for armed forces. They will join us and present their cases. And so you're more than welcome to join. The format of that webinar is different from this Sunday webinar, where anybody can ask any questions and we will be happy to answer. But the Saturday webinar is closed between the faculty and the presenter of the cases, but anybody can listen and attend. So with that, I welcome Dr. Rozina Badal. Please introduce yourself and give your presentation. Thank you.
Assalamu alaikum. I'm Dr. Rozina Badal Munir. I'm an ultrasound specialist and educator. I work in California, Los Angeles. So today my talk is about the central venous access and ultrasound guided. Let me just start my presentation. Okay. Okay, so we are going to talk today. I'm going to give you a few tips and about the technique of the ultrasound guided central venous access in the COVID-19 patients. So we are using the 6 steps approach, which is very easy to remember and to learn. So the first step is that when you are performing the ultrasound guided central venous access, you have to see the anatomy of the vessel under the ultrasound guided, and localize the vessel, check the vessel for the patency, select the insertion site, and then you perform the procedure with the like the puncture of the puncture with the needle, and then finally confirm the needle or wire or catheter in the vein. Now the advantages of this guided procedure is that it decreases the rate of the arterial puncture, hematoma formation, and the success rate in the first attempt. The procedure is that you take the linear probe, and under the aseptic technique, you will have to cover your probe with the in a probe cover or a sheet, and use the sterile gel. Always try to have a clear view of the monitor. Patient positioning is also very important. So if you see over here, the neck of the patient is clearly exposed. Now in this cartoon, I showed you the position of the operator. So the patient is lying over here, and the operator usually stands on the along the head of the patient, along the head of the patient side, and you see the non-dominant hand is holding the probe, and the dominant hand is holding the syringe with which you puncture the vein. And now the site of the monitor is such that you can see very clearly the screen. So this is very important for the operator, that everything should be in the same in the line of the side, you can see the monitor very clearly. And this type of approach is called the single operator technique. because the operator is also performing the procedure, and the operator is also looking at the screen. So this is easy because you control both the probe and the looking at the monitor. So now here we will give you a little bit tip about how to identify the anatomy. So you put your probe on the patient neck. So always remember that the orientation is a very important point when you are performing any procedure, or when you are performing the ultrasound procedures, or you are scanning. So on every probe of the ultrasound, you will see a monitor, a marker. So if you look at over here, the marker is here on the probe. And then on the screen, you will also see a marker, which is different machines have a different symbols for the marker. So I'm using a handheld probe, and the marker is on here on this side. It is written as right. So the marker side on the screen and the marker on the probe should always be on the same side. Now, the very easy way to check the correct orientation is that you just tap on the footprint of the probe, and you will see a turbulence on the same side. So this will make sure, so this will help you to be sure that, okay, your probe is in the right direction. Now, the direction is very important, because otherwise you will get a left and right, confusion. So always check your correct position of the probe. Now, when you put the probe on the neck, you will see on the top, this is thin is the skin of the, this is the skin of the neck, and this one is the sternocleidomastoid muscle. And then you will see this rounded, one rounded and one a little bit a bigger diameter structure. So this rounded structure is the common carotid artery, and the one which is a bigger structure is the internal jugular vein. So these are the two structures. If you look at over here, the common carotid artery will show pulsation, and it will be a little thick wall, but the internal jugular vein will be a bigger diameter, and the pulsation will be more like with the respiration. So this is the short axis view. If you look at over here, my probe is in the transverse direction. So this is the short axis view of the vessels. So this is the video clip. So look at over here. This is the carotid, and this is the internal jugular vein. I'm scanning from the clavicle all the way towards the patient face. So look at over here. Look at the movement of the vessel. It collapses just with a slight pressure. It collapses while the carotid is not collapsing. So here I have put the probe in a longitudinal direction. So look at over here. This is the common carotid artery, and this is the internal jugular vein with thin walls, and you can see the valves of. Let me just show you. Yeah. So you can see the valves also over here. You see this one, and look at the thin walls which are collapsing. So so we see both the in a transverse plane and in the longitudinal plane. Now, in this, when looking at the longitudinal and the transverse plane, you look for any kind of thrombus, for any other pathology. So it is very important to evaluate the vessel before performing the procedure. So now comes the talking about the important step, that what position, selection of the site. So when you put your probe in a transverse direction and select that position of the internal jugular vein for puncture, where the vein is adjacent to the common carotid artery, not on the top of the common carotid artery, because this will avoid the puncture, accidental puncture. So always remember that the vein should be lying adjacent to the common carotid artery. So once you select your probe, so select your position of the puncture site. So then there are two techniques. One is to perform the puncture while keeping the probe in the longitudinal direction where you can see the longitudinal plane of the vessel. So this is called the in-plane technique. So once you insert the needle, inject the needle. So look at over here, I keep the needle right in the center of the marker, and by looking at a 45-degree angle. So when I insert, while inject the needle or puncture the tissue, so you can see the entire length of the needle. So in a plane technique, you can see the needle in its entire course, and you can see the tip of the needle right in the center of the vein. While in the out of the plane technique, you keep the probe in a transverse plane, and you keep the needle right in the center of the probe, in the center of the probe, and at a degree of 45-degree angle. And when you insert it, so you will see in a transverse plane, you will see the needle as a small white echogenic dot. So you will not be able to see the entire length of the needle, but you will see just a small dot. So it's very important for a trained operator that they should follow the dot as it is extending from the skin all the way towards the vein. Most of the operators like this technique because you can see but again, it depends upon the practice of the operator, whichever mode he or she adopts, whether the in plane or the out of plane. So the main purpose is that you see the needle when it is inserting into the vein, and it should not puncture the posterior wall. So the last step is that in a longitudinal direction, in a longitudinal plane, you will see the entire length of the catheter or the wire inside the vein. Here are few of the pitfalls while performing this procedure. Sometimes the person injects so slowly the needle that it dissects the intima and media, and you will make a false lumen, and you will inject the wire in the lumen, the false lumen, and this will give another complication. So it is important that you inject the needle in just one, but a quick puncture. Another pitfall is that sometimes when the person put the needle in the vein, on the monitor you will see that the needle is inside the vein. But if you make a transverse direction of the probe, you will see that the vein is here and the needle is adjacent to the vein. So this is called the volume averaging artifact. So always remember that whenever your needle punctures the vein, you will see a small indent in the vein, and also you will feel a pop. So the pop and the indent in the vein are very important sign in order to avoid the volume averaging artifact. Just few tips are that don't puncture the vein very close to the clavicle, because in that case you might puncture the pleura. And always pay attention to the depth of the vein. So if you look at over here, the skin is here, and I can very easily have an idea that what kind of needle length should I pick for puncture into the internal jugular vein. So look at here, my measurement is written, all the scale is over here, and this is my vein. So I can easily select a proper length of the needle. While performing the procedure, always look at the artery and the vein simultaneously, and also be careful not to insert into the neurovascular bundle. So this is all about the ultrasound guided central venous catheterization. Thank you so much. I'm done, Dr. Shahid. Hello?
जी Thank you very much, Dr. Badal. Assalamu alaikum. Thank you very much. Dr. Shahid had to step out, so he asked me to help moderate. So assalamu alaikum, everybody. My name is Majid Shafiq. Thank you very much to everybody for joining, and thank you, Dr. Badal, for this excellent talk on the practicalities of ultrasound-guided central venous catheter placement. We have asked people, everybody who has joined in, thank you very much to everyone for joining in. If you have any specific questions, please go ahead and list them in the Q&A section over here. We also have some questions that have come through the WhatsApp group, and I will take them one by one as well. First, I would like to give a minute to Dr. Nahid Usmani and see if she would like to add anything, make any comments. Thank you for joining us, Dr. Usmani.
Assalamu alaikum, everyone. This is so important and useful. I think central venous lines are essential for managing all critically ill patients, and having this very practical and important webinar, which all attendees will be using on a daily basis, is very relevant to the current COVID crisis. So welcome everyone, and thank you Apna Merit team and Dr. Majid for arranging this. Thank you.
Well, thank you very much for those comments. We have a few other expert panel members today as well. I would like them to kindly introduce themselves and their specialties as well, one by one, starting with Dr. Nigat Ahmed.
Assalamu alaikum. I am a professor of rheumatology and head of the Department of Rheumatology and chair College of Physicians and Surgeons Rheumatology. Very much appreciate the effort by Apna Merit, and I really have learned a lot from here. I'm extremely grateful, in this part, trained in US and being here. I'm so closely connected to you all, and I think this was an excellent talk because we need more intensivists, and we need more people trained in procedures, and it is the need of the hour here, because and I think we need such kind of workshops, and it was an excellent talk. Thank you so much.
Great, thank you. Dr. Awais Masood, would you like to mention your name and specialty as well?
Oh, I thought I was just a listener, but thanks. Can you hear me?
Yes, we can hear you.
No, it's a very good talk. I enjoyed it, and it's very important. I actually remind me my days. Actually, 3 years of my life, I was just work in a cath lab as interventional nephrologist and putting line 7 or 5 days a week. And again, this is ultrasound has revolutionized all the concept. Is very easy, very safe, and it's needed everywhere. And I think in Pakistan, people should use it a lot. And this kind of training should be continued from one person to another. Very nice talk. Really enjoyed it.
Thank you. And Dr. Masood, are you a nephrologist at present, or is that how you're practicing currently?
No, actually, I'm an intensivist and nephrologist.
Okay.
Yes,
great.
yes, yeah.
That's excellent. Thank you, Dr.
I'm a program director also of a fellowship, which is critical care nephrology fellowship here in New Jersey.
I see. Great. Thank you very much for joining us. Dr. Farhan Qadir, if you don't mind introducing yourself as well, please.
Ji, assalamu alaikum. My name is Farhan. I'm also a nephrologist. I finished my nephrology fellowship, and I just finished my critical care fellowship, and I'm starting working in New Jersey, starting next month. Having said that, I really like the talk too. I only have one thing to add on. Based on my understanding, teaching multiple residents during my recent fellowship and also otherwise, I think one part which is very important is the draping and the initial part of how you drape the patients, which I feel like from an infection control perspective is as important as placing a line. And the second thing is that whenever I am in doubt whether my catheter has an issue or there's a false lumen, I have used angiocath to confirm my catheter placement. This is a secondary step to help to confirm the line to avoid any catastrophic disaster, especially when our patients are so critical. So those are the only two things I have to add on. Thank you very much. Assalamu alaikum.
Thank you.
Great, thank you very much for adding this. Yeah, and I would second that. The angiocath can be a lifesaver sometimes when you're not sure, and you really need, and especially when you have trainees, you could use the angiocath. And just to expand on that, I'm assuming, Dr. Kadir, you use it the same way that I'm thinking you use it, which is connecting the angiocath to your pressure transducer tubing, such as the tubing that you use for your arterial line as well. And you could then actually get a waveform. So you could pass that angiocath in first, get the the pressure transduction done, confirm you're getting venous pulsation, not arterial, before you go ahead and make the dilation.
Exactly. I have used it both way. I've used the angiocath with the catheter tubing comes in with, and use it against and with the gravity, so that let's say if I'm doing it that I have absolutely no help and the nurses are busy, then it's hard to get everything set up like an A-line setup to get the line. That's I use it, but otherwise the center line kit comes with an angiocath and a catheter itself, which I have used it against the gravity and with the gravity and see if that helps. And another thing I have done when I'm not 100% sure, I connect my angiocatheter, hook it up with my, and which is not a good way to do it, but I have done it, that I have hooked it up with my ABG syringe and send the gas from my A line and also with my venous to make sure that it doesn't take that long. And I confirm that when I'm actually not sure about my line. So I have done 2-3 things, but luckily I don't have to use it a lot. But this has helped me in the past, especially recently, about 2 days ago, in the last days of my fellowship, when I wasn't really sure whether I'm actually in the artery or the vein.
Yes, the blood gas method is also fairly commonly used, and that's a good one. The only comment I would make, Dr. Kadir, at least from my humble experience with using sort of what we call the poor man's manometer. I think that's what you're referring to as far as the gravity. So you're just trying to see whether blood is really pulsating out, as you might expect, through the and if the catheter was in the artery versus is it looking like it's in the vein. I am always careful not to expose the venous system to the atmosphere to the extent possible, because of at least that theoretical risk of air embolism, because of the fact that of course it's a low pressure system, and particularly in patients who might be dehydrated and such, and they already have a low JVP. Now, if you've done a Trendelenburg positioning and the level of your venous puncture is below the level of your heart, the risks are considerably lower, but they aren't zero. So I'd be just a little bit careful about exposing the angiocath to sort of just gravity, if that's what you are referring to.
Exactly.
This is a
sorry.
Just a quick comment, if I can. Actually, I get worried, not worried, actually, it has to be extra cautious when putting the dialysis catheter. I tell my resident and fellows also be extra careful and make sure you are the right position, because that catheter is a bit thicker, like especially the dilator is a bit thick. And if you are actually, your position is not parallel to the longitudinal section of the vein or IJ, you have risk of puncturing the vein. So just be extra careful when putting dialysis catheter.
Exactly. I think those are the times when I get very careful, especially during placing dialysis lines. And Majid bhai, when I did it, I usually what I do, I have ABG syringe which comes with your central line. I hook it up with my poor man's manometry. So I usually use as a suction method and then go it against and above the gravity to see if I still have the pulsatile flow to prevent the air embolism at the same time. But that's a great thought. I never thought about it, but I think that's a great thought to make sure there's no air embolism, and I totally agree with you. But it's just one of those things which I have done before, and it just gives me an extra caution. Yeah, thank you.
Absolutely. No, excellent thoughts. Thank you so much for sharing. We also have Dr. Muhammad Ahmed and Professor Shamsa with us. I will ask Dr. Ahmed to also let us know about his specialty, and then Professor Shamsa, and then we'll take some questions. Thanks.
Good morning. Assalamu alaikum. So my full name is Muhammad Iqbal Ahmed, but that's the way it's come up. I'm a cardiac anesthesiologist in Dallas, Texas at UT Southwestern. So first of all, Dr. Munir, Dr. Rozina Munir, thank you very much. This is kind of an area that's very dear to me because that's what I do every day as a cardiac anesthesiologist. And a lot of very good ideas have been shared. And just to give you the power of ultrasound as a modality, till about 2006, I was doing central lines, a lot of them, but with the so-called blind method. I don't think that's truly blind. It's landmark or anatomical technique. And it was quite safe. But since about 2006, I've not used a landmark technique, maybe occasionally. In an emergency situation. So it's really enhances the safety of the procedure, but still you have to be very careful with your technique and your imaging, as you mentioned. So the one thing I would re-emphasize is not to dilate the vessel unless you are sure that you are in the correct vessel, using the many methods that have been outlined. Now, I have used the poor man's method, attaching a piece of tubing primed with saline and using it as a manometer. I've attached an actual transducer line. But I've stopped doing that even in infants because it adds a certain step. And our catheter and the veins clot up very easily. So the priority is to get your catheter and dilator and everything as soon as possible. So what I've found, at least in our experience, we have not, and I'm talking about my entire group, we put hundreds of central lines every year in every age range, is that if you use the ultrasound imaging rigorously, the chances of going into the wrong vessel are very, very small. We have not dilated a carotid for many, many years. So really visualizing your vial when it goes into the vessel before you dilate in both the longitudinal plane and the transverse plane, and you can open up the vessel all the way to the brachiocephalic vein with your imaging in a longitudinal plane. And that has really avoided the complications of cannulating the wrong vein with a large catheter, a dialysis catheter, a cordis, etc. On the procedural aspect, I think we have to be extra careful in this situation with COVID-19, doing any invasive procedure. And of course, the PPE, the draping, but also exposing the equipment, the ultrasound equipment to the patient. So I think some additional steps have to be taken in the form of a checklist, especially for these patients. So a checklist is a great idea for central lines regardless, and I think most of us use them. But there has been some adjustments to the COVID-19 central line procedural checklist because of exposure of of the equipment. So using probe covers, discarding them appropriately, covering the ultrasound machine with a drape, etc., and trying to do these procedures all in one process. So let's say you're intubating and placing a central line at the same time. So doing them in some sequence. So thank you very much. That's all I have to say. Appreciate the opportunity.
And it's a pleasure, to have you here. Thank you so much for those insightful comments. Professor Shamsa, please go ahead and introduce yourself as well.
Assalamu alaikum to everybody. I am Dr. Shamsa Humayun, Head of Obstetrics and Gynae Department at Fatima Medical University, Lahore. I joined little late, but for all of you, when we were discussing about COVID during Ramzan, then the COVID patients were in our hospital were in stage 1, and now every day we are getting critical patients in pregnancy, dying, and almost all high dependency unit and our ICUs are full of patients, and many a times beds are not available for the patients, and so this is the situation here in our hospital.
Thank you very much for sharing. Very sad to hear that. Of course, we are all seeing the uptick, and you laid out a very good sketch of the timeline, right? In Europe and North America, we saw a major uptick in cases actually before Ramadan and then during Ramadan as well. And part of it might be a function of how urban and interconnected a country might be. Of course, in Pakistan, there's been a little bit of a delayed surge. A lot of us are now almost celebrating the end of the first peak, whereas in other parts of the world, near and dear to us, things are going from bad to worse. We're very concerned about that. Well, thank you to everybody for being here. Since we're on the subject of central venous catheterization, one of the questions that was asked was to make comments about use of the subclavian approach, and maybe I'll have Dr. Iqbal Ahmed comment on that, and then if anybody else wants to chime in further, please raise your hand and I'll loop you in as well. Dr. Iqbal, what would your take be on using the subclavian method for these patients?
So absolutely, it is. This is the first approach that I learned as a resident back in the day in the Mayo Hospital, Lahore. And the way I learned it was without supervision, opening up by surgical handicraft and going through the steps. And not that I would recommend that to our current generation of trainees, do this under supervision. But the safety of the subclavian technique is well established. There is a significant, small but significant risk of pneumothorax, but that can be really avoided by correct positioning and approach. The problem with the subclavian approach in the ultrasound guided era is that it's not very easily amenable to ultrasound imaging. The clavicle being bony structure causes an acoustic shadow which obstructs the vein in its typical insertion point. But there are ultrasound approaches to subclavian a little more proximal, going towards the shoulder a little bit and just imaging. There's a supraclavicular approach, which is in plane, and it's completely in plane ultrasound guided approach to the subclavian and brachiocephalic vein. So I would not discourage you from doing subclavian. The other reason to use the subclavian vein is that you don't really want to use the internal jugular vein in any patient who has, for example, come in with trauma, has a neck collar on, and the cervical spine has not been cleared, has some sort of infection in the neck, has increased intracranial pressure. You don't really want to include the venous drainage of the head and neck. And sometimes, at least in our patients, a lot of our patients have occluded vessels. And I'm sure Abbas Masood will agree that a lot of their patients, nephrology patients, who've had multiple vascats and other access lines may have occluded internal jugular vein. So again, the subclavian is an excellent, there is a brachiocephalic inline ultrasound guided approach that I can share with interested people in terms of videos, but it's not to be discarded. I think it has a real role in intensive care, and you know, I'll be happy to answer any questions about that.
So thank you very much.
This
Yes,
is Vyas Masood, can I have a quick comment?
Of course, of course.
Okay, as Iqbal said, I mean, I'm a nephrologist, so I have kind of resist myself to saying something about regarding nephrology patients. So what I have done, or I've seen during my days or years of as interventional nephrologist, any patient who has been on dialysis, so please make sure that before you start the procedure, you make sure that the IJ is patent. Sometimes you see that big IJ, but it's not, I mean, you cannot compress it. And it's open at the opening, but after that is you know, stenosed, or you cannot, and you're stuck. So that's an important thing. Another important thing, that any patient who is in CKD stage 3 or beyond, who will be, can be, or may be on dialysis in years from then, obviously would like to avoid subclavian approach, because that can cause stenosis, and IJ is the best approach for those patients.
Great.
Thank you.
Thank you very much. You know, very, very insightful, both of you. You know, and this, I hope, you know, everybody who's joined in today, who's listening, and anybody who might be listening later for, you know, the recorded version of this, takes home one important message that, you know, there are more than one ways to skin a cat. You know, the really important thing here is to know what you're doing, be good at what you're doing, if possible, have supervision available when you're doing it if you haven't done enough of those techniques. You know, the ultimate name of the game is, of course, central venous access. And if you're good at the approach that you're about to take, that becomes, in the majority of cases, the preferred approach. There are always going to be some relative and some absolute contraindications to picking one approach versus the other. But in general, the important thing to remember is to know what you're doing. You know, one related example to this is the subclavian. When we're talking about the subclavian approach, as Dr. Iqbal, you know, also alluded to, there are ways to use the ultrasound as well. However, that's not the approach that many people who do place lines in the subclavian vessel take. If they don't do it, you know, using the ultrasound for the first time without supervision and then trying to base your subclavian approach on that would be fraught with excessive risk, because that's not the approach you have taken. In 2020, the standard of care for internal jugular venous catheter placement is 100% of the time using the ultrasound. So in the US, this is expected. It's part of the standard of care. You have to use ultrasound if you're going to be cannulating the internal jugular vein. With subclavian, you can go with or without the ultrasound. If somebody is doing internal jugular venous catheterization in Pakistan on a patient and they've never used ultrasound, I wouldn't discourage them from using ultrasound, but it would be very important to arrange for supervision as well, because all of these things, you know, it's one thing to get didactics, and we got an excellent didactic on this today, but that has to be coupled with, you know, real-time hands-on supervision as well. So we're gonna switch gears a little bit, and there are a few excellent questions related to COVID-19 management that have come through our WhatsApp group as well. One question which is obviously very pertinent at present, as Pakistan is grappling with this supply versus demand mismatch. People, you know, who are infected and who are sick, they're increasing exponentially, but the hospital capacity, of course, is not really changing from day to day. So one question is, what level of oxygen saturation is indicated for admission? Which of the panelists would like to take that first? Dr. Avais Masood, would you like to take that? You're muted currently.
Okay. Actually, there's a difference between practical approach and theoretical approach. We say that if patient has oxygen saturation less than 94, then you should be worried about that. But I have seen in Pakistan, I'm dealing a lot of people over there, not dealing like I'm part of my suggestion. I would suggest that in Pakistan, you can go down, you keep pulse ox with you at home and keep monitoring your pulse ox. And if you are able to keep your pulse ox more than 90 at room air, you should not go to hospital. Okay, again, this is a practical approach. It's not like theoretical approach, because in hospital, and if you're stable in that, you're okay. You should be in close contact by the phone with your doctor and listen to your doctor, and doctor advised you to go to hospital, then you should go to hospital, obviously. And if you have any heart history and your close monitoring of your heart is needed, continuous, then you should go to hospital. Otherwise, keep pulse ox, and if your oxygen is stable, oxygen saturation more than 90%, and you prone yourself at home most of the time as you can, just stay home. Going to hospital is a lot of problem. If you not do bad by the COVID virus, you will do bad because of once you see the bills. So that's actually a practical approach. So pulse ox, keep in close contact with your doctor over there. And if you're deteriorating, then go to hospital. If you're stable more than 90%, that's fine.
Abbas, this is Iqbal. I just have a question about that. I agree with that approach in practice, but how does that affect the spread of the virus from a positive patient into the family, which may be a large extended family living in the same household at home?
I mean, yeah, it depends on the situation. If they can isolate themselves, obviously that's the first approach. I mean, they don't want to spread the disease to the family members. But the hospitals are packed, and the folks in Pakistan, they know better than I do that what's the situation there. And they actually can comment more there that whom they will recommend to go to hospital, whom they will like to stay. But I have personally dealt with majority of my, not patient, like people who are involved with their doctors, so they are obviously more comfortable and monitoring themselves, and they are in close contact with their colleagues over there. So that's my experience over there. A couple of people, they actually went down to sometime even like slightly less than 90, and eventually they did okay, but they were stable. They were able to take oxygen at home also. But I would like to say as much as they could stay home if they're not deteriorating. That's my approaches in Pakistan. But again, folks in Pakistan can comment better than I do because I'm not there.
Great, thank you very much. And related to that, there's an excellent resource that just got published. Actually, it's in press right now. I just shared the link in the chat, in the chat forum window over here. I would encourage folks to, go to this website, perhaps print it out or save it on their computers. But it's a very good sort of treatise that talks about the pearls and pitfalls of home-based pulse oximetry. One of the big questions is, if you're going to be checking your oxygen levels at home, should you be using the commercially available finger pulse oximeters, or should you be using smartphone-based apps? So, smartphones, the Apple iPhone and the Samsung Galaxy, they have apps too that make you put your finger on the camera and use the flashlight to see what proportion of the light is reflected back. That's a different physical mechanism from how the pulse oximeters that we're familiar with in the hospital, and also the ones that are commercially available work. They work differently. But so I think one of the take-home messages from this article that looks at some published data on both of these is that the smartphone-based apps are really very unreliable, and they cannot really be relied upon. Obviously, if you're completely in a pinch, you could consider using it. As a physician, I would have strong reservations about going off of that at all. When it comes to finger pulse oximeters, there are things to keep in mind. and I'll just quickly rehash them for in 30 seconds or so, but you need to make sure you're resting comfortably for at least 10 minutes or so. You need to make sure that when you put your finger on it, the finger's warm enough. If you're not getting a good signal, try to make your finger warm first. Make sure you're not wearing nail polish that can adversely affect the reading. And then make sure that you are looking at the reading for a good minute or so, and then take the reading that's the most common one, not just the first figure that comes on the screen. So thanks for those. Now, there is an important question, I was sort of bracing for that, and that question is about the use of dexamethasone. Of course, we've all heard about this, the latest stop in the, I should say, the COVID circus, right? The current stop is at the dexamethasone station. And looks like Dr. Farhan Qadir would like to answer this question. So please go right ahead, Dr. Qadir. You're muted. Let me see if I can unmute you. Mr. Walid, can you unmute Dr. Qadir?
Hello?
All right, perfect.
Hello? Can you hear me? I'm so sorry. I can't hear anyone.
I can hear you. Can you hear me right now, Farhan?
I'm so sorry.
Let me see.
I'm going to mute myself because I'm going to rejoin again because I can't hear anyone, so I'm so sorry.
Well, waiting time, this is Wes Masood. Can I comment on this dexamethasone thing for like a very briefly?
Of course, absolutely. Go right ahead.
Yesterday talk, there was a very important question. Somebody asked that, they said that we are using Solomedrov. Should we have to, because after this study, do we have to transfer to change to dexamethasone or we continue? So in my opinion, I mean, it's basically the study showed that you need to do steroids. And the second thing that you need to do a low dose. So that's, I think that you don't have to change steroids if you already taken like Solomedrol or any other steroids. The idea is to keep it low dose. You don't have to go super high dose. So they use 6 milligram of dexamethasone. It's a long acting. Solomedrol is a relatively intermediate acting. And comparatively dose, you need to do that. You can do it 20 milligram twice a day or 25 milligram twice a day. You don't have to change steroids if you're already taking and giving patient, but keep it at low dose.
Great, thank you.
Can I say something here?
Of course, go right ahead. Dr. Nigat.
Yeah, so the current situation is crisis here.
We can barely hear you. Could you speak up a little bit, Dr. Nigat?
Okay, can you hear me now?
Yes, much better. Thank you.
Okay. So this is a crisis situation here because beds and very difficult to manage patients at home, but patients are staying at home and now are being managed at home by their physicians. We have picked up, I at least have picked up like 10, 12 patients during the last 10 days who were rheumatic disease patients, and just picked them up on telemetry, and half of them are being managed at home. But the situation is this, that pulse oximeters have disappeared from the market here. They're not available. Very difficult to find them. People are keeping oxygen supplies at home in the form of an oxygen concentrator, and they are not available in the market. Very difficult to find. There is a wait for like a month for some of them. Dr. Majid, I'm so happy you talked about the pulse oximetry, and I actually took the link to tell people, because most of the patients who are being managed at home with oxygen and not desaturating, and have other parameters like CRP and ferritin and all okay. So they really can be managed at home. But with this problem of not having the pulse oximeters and oxygen concentrators at home, the situation is very difficult here.
Great, thank you very much, Dr. Farhan Qadir. I promise I will get to you. Dr. Iqbal Ahmed has his hand raised as well, so I will let him speak first. Go right ahead, sir.
Thank you, Majid. So I just want to go back to the article that you mentioned about pulse oximetry, and I think I really have to emphasize not to trust the iPhone or any kind of smartphone apps, because as you know that pulse oximetry is based on a physical principle of infrared, near infrared light absorption at very specific wavelengths. So it has to be a monitor and light emitting diode that is emitting those wavelengths and a sensor that can sense the absorption. As far as I know, no smartphone technology as yet. It may happen, but this is not something that I would recommend to anybody to use at the moment. Heart rate measurement, yes, that is pretty reliable based on studies, but pulse oximetry, I understand that there's a shortage, and we in our overall global community have to come up with a solution to provide developing countries with pulse oximeters. One of the solutions is an organization called Lifebox, Lifebox, which manufactures and supplies low-cost, reliable, validated pulse oximeters to developing countries. So for Dr. Nighat, I would say that, if you can look them up online, or I'm happy to share resources that may help with the supply part. So, and while I'm here, I just want to mention, going back a little bit to the Subclavian approach. I think one of the things I wanted to say was that if you had in the ICU, you have a patient who has already has a pneumothorax on a side, let's say right side, and you want to put a subclavian line, and that's the side you want to attempt it if they already have a chest tube. So not attempted on the opposite side.
Great, thank you very much. Dr. Farhan Kadir, I'd like to hear your thoughts on dexamethasone as well. Sorry we lost you there. Thanks for rejoining.
Assalamu alaikum again. In terms of dexamethasone, I think because of the DexArts trial and then this recovery trial, which is not published yet, I was talking to my colleagues just to get their expert opinion, and we were thinking about changing our practice and considering dexamethasone in the moderate to severe or very severe ARDS because of the number of needed to be treated. Again, the DexArts, as we all know, that the viral pneumonia and normally in generalization, the DexArt was treated. The only thing was, when I was talking to them, and was thinking that dexamethasone is a good medication probably, but one has to think about if the patient is in septic shock, probably dexamethasone as a choice for your steroid is not the ideal medication because it does not have as any mineralocorticoid activity. So just to keep this in mind, to make sure that if you are in a state of shock and you want to need steroids, if you're a steroid believer, you probably have to think about something else which is equivalent to dexamethasone. How much it will help, but it will be equal in dose. So that's the only thing I have. Would I probably use dexamethasone? I would probably use personally on my moderate to severe ARDS patients in near future. I would like to hear from you guys too. Thank you.
Thank you.
Yeah, this is Dr. Vas. So just quick comment on this steroids. So if you're in septic shock, the best, not the best, but the more recommended is hydrocortisone. Because hydrocortisone has some mineralocorticoid effect also, activity also. And the equivalent dose to 6 milligram of dexamethasone could be 50 milligram IV twice a day. That, I think.
Great, thank you very much. And these are very helpful comments. I would only add to this, for everybody to remember what we're going by right now. The question of steroids in ARDS is it's an eternal one. We've always been grappling with this. We've looked at steroids in severe pneumonia as well, even without ARDS. There's never been a conclusive yay or nay answer to these. What we're dealing with right now is something that has played out multiple times in the past 2-3 months, which is that we are dealing with a promising study that is yet to be fully peer reviewed and yet to be fully vetted, and certainly yet to be corroborated by another independent study. So there would be some room for healthy skepticism, although it seems to make sense that perhaps the potential benefits do outweigh the potential risks, which there are some, in people who are sick enough to require oxygen or mechanical ventilation. One thing among the many others that one can sort of look at, that I'm sure peer reviewers are looking at from this latest study, is that it appears that the control arm, which was worse off than the arm that got the dexamethasone, that control arm seemed to have an excessively high mortality, which isn't quite borne out by our experience here in North America or most other places when looking at hospitalized patients. That makes you wonder, why were the other people dying so much? Was there something else that was different between these two arms as well? But I'll leave it at that. One question that has come up frequently is the role of ivermectin. I feel like this question gets posed quite a bit. Dr. Awais Masood, would you like to take that question, the role of ivermectin in COVID?
No, I don't, because I have no experience. And when I talk to my ID colleagues, they just laughed at it. I mean, it's not laughing matter. It's a real thing, and people have been experimenting with this medication, and it could be a potential medication, but I have no experience with that.
Can I say something?
Yes, please, go right ahead.
With dexamethasone, this has come up lately with the recovery trial, but did they have, why did they have a comparative trial with Solimedrol, because that has been used for the past 2-3 months in moderate disease and showing good results. So if you compare it with no intervention at all, I don't understand why don't we have an arm where you compare it with methylprednisolone.
Yeah, that's a good point as well. Several
I mean,
get raised
one reason, I mean, they just picked one steroid because this is a cheaper and long-acting dexamethasone, and probably that's why they picked it.
Right.
I think so, yeah. But now dexamethasone is disappearing from our market, actually.
Right.
So this is Iqbal. I think that's exactly the question I had with, and Mohsin Zaman, who's part of our panel group in Northampton in UK. He was one of the investigators on one of the centers of the recovery trial. And the reason they chose dexamethasone was the way the trial was designed. It wasn't the nature of the drug itself, except for perhaps its duration of action. They thought the way that would be the most appropriate one to use in the steroid arm. And they, as you know, have several other arms comparing other things, but this is the preliminary results that came out first. So dexamethasone choice was the trial design, not necessarily if it's better than Solimedrol or anything else.
It's similarly like in hypertension trials, they use chlorthalidone all the time, night hydrochlorothiazide, because chlorthalidone is a long-acting medication, and as compared to hydrochlorothiazide, and probably the same reason, and it showed better results.
Right. So the practicalities, of course, of conducting the trial and all of that. I will try to sneak in a couple of additional questions, and then we'll wrap it up. Another, we have talked I really like the fact that we have had a chance to talk in some depth about pulse oximetry today, because of course it's very relevant, especially given the limited resources. One excellent question here posed by one of our attendees is, what about the use of respiratory rate in the absence of pulse oximetry? Dr. Farhan Kadir, would you like to take that question? You're muted currently. Go right ahead.
Yes, I think the pulse ox, respiratory rate, work of breathing, underlying medical conditions, these are all the good parameters, or actually one of the few parameters which we use When we actually assess a patient, absolutely respiratory rate itself is an important parameter, which will tell us that your work of breathing is, and it also tells you about the patient's possible underlying clinical condition itself. Yes, we need the numbers, which is pulse ox, but at the same time, overall clinical situation, including the respiratory rate, would be good criteria. If you look at most of the data, they actually recommend anything respiratory rate more than 22 to 30 is considered to be moderate to severe respiratory distress. So essentially respiratory rate is a good parameter to look for the patient to see severity as well too. Thank you.
Great, thank you. I think that was, that was well said. And of course, that's you look at the patient's baseline. It might be hard to sort of have to rely on a patient's caregiver to accurately count their respiratory rate and then relay that, as opposed to, of course, a digital reading, for instance, from a pulse oximeter. But for GPs, for telehealth providers, for lady health workers, etc., respiratory rate, when you look at what the patient's baseline is, and then you see an increasing respiratory rate, it speaks volumes. And sometimes when I, go in to see a patient on the floor and have to decide whether or not to bring them into the ICU, I'm sure Dr. Kadir and Dr. Masood and Dr. Iqbal and others have had similar experiences. Sometimes the respiratory rate being high is the only thing you really need to know to make that decision. Let me quickly get in one additional question, at least two, and that's an important question as well. Somebody asked, when do we need to repeat COVID PCR once the patient's diagnosed with COVID-19 who's managed at home for 2 to 3 weeks? Dr. Awais Masood, would you like to take that?
Yeah, so the question is, a patient is at home, he was positive and went to repeat once he or she recovered, right?
Correct.
That's the question?
Yes.
I mean, depends on that, why they have to repeat. I mean, if they have to go back to work, obviously you don't have to repeat. If you are like 7 days without any symptom, without any fever, you can safely go to work. But if you have to repeat, I mean, the thing is that you can repeat after a week or so, you have to repeat twice, but the thing is that it can be positive and you could be non-infectious sometime even after 4 weeks. So I don't know the significance or importance of repeating it. Maybe Dr. Kadir has some other, some different, or like to hear about his opinion.
Great, thank you. Dr. Kadir, go right ahead.
I totally agree with Dr. Masood. I don't think so that there is a set criteria right now or the standard criteria, but it all depends on the institution where you work at. Based on my talking to my different colleagues, coming back to work is pretty institutional based. I'm not really sure in Pakistan, but definitely isolation is pretty set, and it is a strict criteria that once you're positive, you got to be isolated for 2 weeks or 14 days. In terms of repeat testing and can you have a false positive testing, it's pretty well documented. And the data shows that you need a broken particles and broken RNAs, which can cause the persistent positive testing. Even people with a negative COVID through the nasal swab and the bronch cultures came back positive, did not have a clear significance. Either we don't know yet, or it probably has no significance itself. There's some fecal shedding for almost like a month, which absolutely has no significance based on there's no fecal odor transmission. So I totally agree with Dr. Masood. It's institutional based. There is no clear-cut guidelines when to retest these patients. Thank you very much.
Thank you. Absolutely. I would second or third that as well. But really, there is the CDC lists it out nicely on their website as well. But last I checked, there is actually no evidence whatsoever that any samples, any virus or virus particle obtained from a patient who developed symptoms, let's say 10 days ago, was able to be cultured, was able to, grow in a culture medium. What that tells us is, just like Dr. Kadir mentioned as well, even if you have PCR positivity after, say, 2 weeks of having had documented COVID, it might just be referring to whatever leftover dead pieces of RNA might still be hanging around in your body, but it might not reflect transmissible disease. It may not reflect pathogenic disease. Obviously, some people take much longer to heal from the disease. A lot of it might have to do with their own inflammatory and immune responses. It could represent sequelae of the disease, thrombotic phenomenon, this and that. But it seems that by day 10 or so, everybody, as much as we have been able to tell through studies, has cleared the virus and is no longer is no longer contagious, is no longer able to infect another person. So once somebody is feeling better, I think most institutions, most places will say there is no stringent need to get another testing done. Obviously, if your institution, if your employer has specific policies, you'd have to go with that. We don't have any raised hands among the attendees. Maybe I would ask one last question, because it's related to the topic that Dr. Munir spoke about today. One physician attendee, Dr. Fawzia Salahuddin, has asked us, if there's one site that we feel is preferable specifically for COVID patients in terms of central venous catheterization from the standpoint of being more or less prone to developing DVTs. Dr. Iqbal, would you like to take that first?
Yes, I don't think that we know that. At least I'm not familiar with one site being a higher risk of developing DVT. But, it means if still the internal jugular vein is preferable because of its ease of access and ease of visualization, and most people are very familiar with. The other sites, like especially since we do have an incidence of DVT, which is significant in the lower extremities, in the pelvic veins, maybe that may be an indication to avoid the femoral access. But if you don't have an option and you want to resuscitate a patient and save their life, and femoral vein is the only thing, you can place it, get them stabilized, and then change if necessary, and monitor their coagulation status and their clotting status. So I don't know, and I can, let others opine on this.
Great, thank you. Any other thoughts, Dr. Awais, Dr. Farhan?
No, I think it was a great discussion. I enjoyed it a lot. I don't have anything to add. Thank you.
So I do have one comment, Majid, and that is to do with the home monitoring of patients without a pulse oximeter, for example, and using respiratory rate as an indicator. So respiratory rate and breathing pattern is a very powerful indicator of the trend of respiratory illness. But you have to be careful in not just looking at the rate on its own. One of the problems with that is that when patients have a high work of breathing and they're been panting away at a rate of 25, 30 for a while or higher, the work of breathing can exhaust them, and the rate can slow down just before they become very seriously ill. So a slowing respiratory rate in somebody who's ill may not necessarily mean they're getting better. One of the things that can help is whether they can complete a sentence. If they can breathe, or their breathing is easy enough for them to speak and complete a sentence and not be exhausted in just saying a couple of words. I mean, I think that could be added to home monitoring with or without a pulse oximeter, or a general assessment of their exhaustion.
Excellent. Thank you very much. Any other questions, thoughts, comments? Anyone would like to add anything? Dr. Munir, would you like to add anything at all before we wrap this up?
For subclavian, I will just say that if you have availability of the small footprint probe, so that helps sometimes, you know, to look through the supraclavicular or infraclavicular approach. So, but again, it depends on the availability of the small footprint. And another point is about the use of the handheld device now, because it's very common in, easily available also in US, and prices are also very low. So in COVID patients, if we prefer to use the handheld devices, because in that we can very easily perform the PPE. So this is just 2 points which I would like to add.
Thank you very much. Well, thanks everyone for not only joining, but staying with us, you know, to this hour as well. We hope this discussion, you know, helps you as you try to manage patients. It's a difficult situation, and kudos to everyone who is really working hard on this. May your efforts be rewarded. Please join us again next week, and we will once again be hosting a similar session. Please bring your questions as well. Thank you very much.
Thank
Allah
you.
Hafiz.
Allah Hafiz.
Allah Hafiz, thank you.